invite next speaker, Professor Liu, talk about how to manage very difficult little stones. Yes, yeah, yeah, difficult kidney stones, please.
Okay. Good afternoon, everybody. Today's my topic is how to manage complex renal stones. This is the natural history of the residue stones after PCNL. You can see 45% had residue stones. If the fragment larger than 4 millimeter, 28% cases will need another operation. And the fragment less than 4 millimeter, 16% will need another operation. So the highest rank of PCNL is removal all the stone as possible as you can. For simple renal stone, single track PCNL is enough. But for complex renal stone, the stone-free rate of single track PCNL is only 44%. So we should combine many methods such as combine SWL, combine RIS, combine integrate, flexible laparoscope, or multiple track PCNL. So what is the treat options for complex renal stone? Someone said you should center on PCNL, and others said you should center on RIRS. But in the EAU guideline, percutaneous laparoscopy remain the standard procedure for the large renal calculi. So I think for complex renal stone, we will center on PCNL. For the residue stone, we can combine SW. It is suitable for treat residue stones less than 2 centimeters. You should not combine SWL. But the result is influenced by many factors, such as stone size, stone hardness, and the condition of the caries. In the AUA guideline, the stone-free rate combined SW is only 66 to 81%. The second method, we can combine flexible laparoscope. If you perform standard PCNL, you can combine 18 French flexible laparoscope. If you use mini PCNL, you can combine RIRS to do it. For this case, you can see if you use flexible laparoscope, you cannot reach the parallel caries. For this image, you can reach the parallel caries. So the effect is influenced by the condition of the caries. You can combine RIRS. We say endoscopy combined intrarenal surgery. You can use two positions. One is the splitted neck prone position. Another position is GMSV position. The stone clearance in splitted neck prone position is 78%. And the GMSV position, the stone-free rate is 82%. It is also influenced by the condition of the candle, such as the IP angle, the length of the and the width of the infundibular. Now, there are many new developments in RIS, such as passive tip flexible UAS and active tip flexible UAS. So someone said we can treat compressed stone with RIRS. and the indication of the iris will be enlarged. Because there are UAS suction. But there are blind spots of flexible ureteroscope, such as IP angle less than 30 degrees, and the width of infundibular is less 5 millimeter, and the length of the infundibular large than 3 centimeter. So this is the blind spot of the iris. For multiple thread PCNL, there are pros and cons. The pros is it is not affected by the residual stone burden, and also not affected by the width of the infundibular and the IP angle. But there are some cons. Maybe more thread, there will be more bleeding, and will sever the renal function. So how to manage the complete renal stone? I suggest 3 combinations. The first, we should combine the ultrasound and X-ray guidance. And the second, we will combine the large thread and the small thread. And the third, we will combine the multifunctional laparoscope and multiple lithotripsy instruments. The first, why we will combine the ultrasound and X-ray guidance? There are many advantages of ultrasound guidance. The first, it is easy to identify where is the dorsal calyx. You place the ultrasound probe in the patient's back. The calyx towards the probe is the dorsal calyx. So it's very easy. But for X-ray guidance, it is not easy. You should inject the air through the ureter catheter. If the calyx with air is the dorsal calyx, it is troublesome. And the second, it is easy to identify where is the calyceal fornix. If we puncture the liquid with calyx, the maximum area may be the fornix. So it's very easy to find where is the dorsal calyx, where is the fornix. The further advantage is we can identify the adjacent organs surrounding the kidney, such as the spleen, the liver, and the pleural. And the fourth is there are low radiation under the ultrasound guidance. So for this case, not very complex stone, renal pelvic stone. He has a coronary artery disease. The coagulant drugs was discontinued for 12 days. But hemophoresis will happen. He only used pure X-ray guidance, low use ultrasound guidance. This patient has pleural injury and the renal artery injury. So hemophoresis happened. We'll use the fluoroscope to remove the blood. So ultrasound guidance is very important. Now I'll show you the X-ray, the advantage of the X-ray guidance. The first advantage, we perform retrograde urography. Urography can provide additional information. For this case, it is a renal pelvic stone. It seems very simple, but under the retrograde urography, you can see it is a branched pelvis. You cannot use one thread to eliminate the stone. We must establish two threads to eliminate the stone. So retrograde urography can provide additional information. And under the X-ray guidance, we can see the angle between the two caries. Under the ultrasound guidance, we cannot see the angle between the two caries. In the KUB, we can say we have positive stone and the negative stone. Also, under the ultrasound guidance, we all have the positive stone and the negative stone. For this case, this is very simple renal pelvic stone, and this is very complex renal stone. You can see all this stone is the positive stone under the ultrasound guidance because there are hyperechoic area and the posterior shadow. For ultrasound, if have hyperechoic area and the posterior shadow, we can diagnose this is a renal stone. But for this case, there are very clear shadow, but it has a hyperechoic area. So for this case, I failure to puncture under the ultrasound guidance. But you use X-ray guidance, it is a positive stone. Under the X-ray guidance, I puncture successfully. So different stone use different guidance. The further advantage is under the X-ray guidance, it is easy to identify where is the guide wire, whether the guide wire is in the collecting system or not. The left image, you can see the guide wire is in the collecting system. But the right image, you can show the guide wire is outside the collecting system. Under the ultrasound guidance, it is difficult to tell you the guide wire is outside the collecting system. It's difficult. The further advantage of X-ray guidance, you can monitor the pathway and the depth of the dilator. For the ultrasound guidance, it's difficult to check the depth and the root of the dilation. For this case, we can see this is the upper ureter calculi. Under the pure ultrasound guidance, the lateral tube was placed into the renal vein. My boss, Professor Sun, he never met this complication. Why? He always used X-ray guidance. So in China, many Chinese urologists only use pure ultrasound. So renal vein injury is happen sometimes. The fifth advantage of X-ray guidance, in the procedure, when we puncture successfully, we will inject some contrast to check your needle whether it's in the collecting system or not. This case, very complex lower renal calculi. The first thread is no problem. The second thread also problem, but you can see the further thread. When we puncture under the ultrasound guidance, we inject some contrast. You can see this is the renal vein. You can see that this is the renal vein. If low X-ray guidance, renal vein venous injury was happen. But if X-ray guidance, we change the puncture route, we can avoid venous injury. So intraoperative urography is very important. This case, also the further thread, you can see when we inject the contrast, you can see the column image. If we low use the intraoperative urography, the column was injured. But we changed the rule. The column injury was avoided. So urography is very important. After we performed one thread, we continue the another puncture. This is the ultrasound. You can see it is difficult to identify where is the residue stone. But for X-ray, it's very clear this way. So sometimes if you puncture failure under the ultrasound guidance, you should use the X-ray guidance. If you puncture failure under the X-ray guidance, you can use the ultrasound guidance. For multiple thread PCNL, the X-ray guidance is very important. So this is our experience. In our center, we also use the ultrasound and X-ray, but ultrasound is first. But for Professor Nami, X-ray is first, ultrasound is second. So it is different. So ultrasound, X-ray, and combine, which is better? Professor Zheng performed a prospective and randomized trial. It can show for simple stone, ultrasound, X-ray, and combine, the efficacy and safety is comparable. But for complex stone, such as stone score 7 to 8, combined X-ray guidance is useful, is important. So for these typical cases, very complex stone, under ultrasound guidance, we eliminate the majority of the stone. There are 3 residue stones. Under the ultrasound guidance, we complete the puncture. But you can see under the X-ray guidance, the needle is not in the residue stones. So X-ray guidance is very important. And the X-ray guidance, the further thread, you can see the guide wire is come out of the collecting system. So X-ray guidance and the ultrasound guidance is very important. Combined is better. The further, I suggest that we should combine the large threads and the small size thread. Why? Today, we have standard PCNL, mini PCNL, super mini PCNL, and micro PCNL. We can use all type of this PCNL. How to choose? The thread is larger. The stone removal efficiency is higher. The renal pelvic pressure is lower. This is the advantage of the large thread. But the larger thread, the more bleeding and severe the renal function. And the number for the standard PCNL may be larger 28 French. The GFR of the affected site will be decreased after surgery. But in our center, for multiple mini PCNL, after the multiple PCNL, the GFR will be stable. Will be stable. So we should combine large thread and the small thread. If the stone size is very large, we can select standard PCNL as large thread. If the volume is not large, we can select super mini for large thread. So there's many type combination, such as standard combined mini, standard combined super mini, standard combined needle, or mini combined super mini, mini combined micro pearl. There are many different combination. So for my opinion, if the stone size larger than 4 centimeter, and the width of the infundibular is wide, and the stone is very suitable for ultrasound infiltration, I will select the standard PCNL. But if the stone size is less than 4 centimeter, or the stone is very hard, we will use the laser, and the stone is not suitable for ultrasound infiltration, I will select the mini PCNL. If the stone size less than 2 to 5 centimeter, I will select super mini or micro pearl. So this is my personal experience. The further is why I will combine multiple functional laparoscope and multiple infiltration instruments. If we perform large thread and the small thread together, we should change different laparoscope, such as standard laparoscope, minimal invasive laparoscope, super mini laparoscope, and the needle laparoscope. So the conversion is very troublesome, and it will have pollution because you will take out the camera, take out the night cable, so it will be polluted. So Professor Zheng invented this multifunctional laparoscope. This laparoscope, they are a core of the rhinoscope. If you use 17 French shift, there will be a standard laparoscope. If you change 13 French shift, there will be a minimal invasive laparoscope. If you use 8 French shift, it will become super mini laparoscope. So the first advantage of this laparoscope, it can solve the troublesome in the pollution. The second advantage is for the standard Wolf standard laparoscope, the outer diameter is 90 French or 21 French. So when we perform 24 standard PCNL, we should use this scope. But this multifunctional scope, the outer diameter is only 7 French. So I only establish 20 French thread perform standard PCNL. 20 French thread is mini thread, not standard thread. But I can use ultrasound infiltration. So this paper show you 22 French is better than the other French, larger than 22 French. So we can use the 20 French to perform standard PCNL. This is the most advantage of the multifunctional laparoscope. The further advantage is sometimes when we perform standard PCNL, it is difficult. Sometimes it is difficult to perform retrograde ureter placement. You change the ureteroscope to retrograde place ureter catheter. But for this scope, you change the small size laparoscope to complete this difficult condition. And the lithotripsy tool to senescent a pulprized lithotripsy tool is very important, such as very hard stone. The hardest stone is larger than 1,300 HU. You should select holmium laser. And for infectious stone, or the CT scan is less than 1,000 HU, you should select ultrasound lithotripsy, or ultrasound combined needle cars. So if you have this EMS, you can use the ultrasound, you can use the laser, ultrasound and the laser, or only needle cars. So we should, according the stone burden and the hardness of the stone, to select the suitable lithotripsy tool. So for this case 1, this case, the stone is larger than 4 centimeters, and the CT value is 650 HU, very soft stone. So you use 120 French, use the ultrasound lithotripsy. It can take only 45 minutes to complete the procedure. The next case, also 4.5 centimeter stone, but the CT scan show very hard stone, 1,500 HU. So I don't select standard PCNL. I select ESMP and SMP. Use laser. It will take only 55 minutes to complete the procedure. And this very complex stone, use the 122, 118, 116, 114 to eliminate the stone. This is the infectious stone. If you use 424 thread, maybe more bleeding. But for this case, I only use 420 French thread. It will reduce the bleeding. So take home message. For complex stone, you should PCNL combine SWO, combine IS, combine flexible laparoscope. But these three methods is influenced by the condition of the caries. But multiple thread PCNL, I think it is the ultimate endoscopic options for the compressed stone. And the three combination can improve the efficacy of the safety of multiple thread PCNL. Okay, thank you very much.
Okay, very nice presentation. I ask a question for everybody. How many people level do multiple axis PCNL? Level do? No. Super. Super. It's okay. Sometimes for complex neurostones, maybe you can do combined flexible ureteroscope combined PCNL equal to anti-flexible laparoscope combined PCNL. You can do shockwave combined. It's okay. But I think for me, I like to do multiple because it's really fast. You can not take a stone size and angle and hard stone, blah blah. So I think it's okay. But Sam, you do multiple axis PCNL?
I do.
Yeah. for me, I usually puncture. I usually puncture the first, and then I check, blah, blah, remove a stone, and then my scope can notice after this calyx stone, maybe. But sometimes many urologists do puncture at first. Is puncture here, put a galvai, and the puncture galvai at the same time. And for you, which method for you?
We like to pre-puncture. Pre-puncture. So if you've got a complex staghorn stone, and you know that the first puncture is coming in this way, and you know that there's a big stone that's completely parallel, that you won't be able to get to it, we would pre-puncture, get a guide wire down the ureter, and just have a guide wire. Because after the first operation, after going in and removing the big stone, sometimes have blood clots, air, gas, perinephric collection, and then the second access can be more difficult. Can be more difficult. Yeah.
Multi-track man is here. I know him for more than 10 years. His approach is very clear. Puncture as much as possible. He does it as much as possible. 1, 2, 3, 4. What was the highest number?
14.
14. Nothing to say, 14. Okay. Here in China, beginning with his approach, he says, first a large bore tract, and then additionally, combination is small bore tracts, but PNF, nothing else. Is that right?
Yeah, that's right.
But if you go to Europe, they say, if possible, don't puncture. Go from below, if possible. Otherwise, puncture once, get the main stone burden out with one tract, and then endoscopic combined for the all calcium stones, residual stones, with flexible approach. Europe, China. What do you say? No place for flexible urologoscopy, endoscopic combined in your practice? Endoscopic combined approach, you know.
Yesterday, I performed endoscopy intraneedral surgery.
Historical moment. So,
decide for a patient, you decide a multi-tract punction. We can do, for example, 2 puncture before dilatation. It's easier to do the puncture, the second puncture before when the dilatation for the first.
Step by step. Perform one and eliminate stone, and then to perform another tract.
Yes,
puncture. Yeah.
What we see, but it's a little bit difficult to do the second.
If you only use ultrasound guidance, it's difficult to perform the another puncture. But under the X-ray, you can one by one.
And then make dilation, the lower stone, sometimes you don't need. Sometimes blood flows, but sometimes extra session. The only thing, yeah, it's a kind of sometimes we call it, but you can do X-ray, flow, and this what's the flow? You can do clots, blood clots, extra session, but not take care of this. No? So you must know two guidance. Yeah, just after X-ray guidance, you must know how to do it.
My question is about the function of the kidney after multiple punctures. You said on one of the slides that the GFR is not changed.
But do you think if we go to do a nuclear study for the function of the kidney, like the DMSA or MAC3, do you think we will find that the function of this kidney is decreased?
In the publication, you can see if you perform multiple thread, each thread is larger than 28 French. The more thread, the renal function will decrease. But for mini PCNO, maybe under the less than 5 thread, the renal function will keep stable. For me,
Yes.
for 13 threads, the renal
So
function also stable.
It's punctured 14 times.
2 years. The renal function keeps stable.
Compared to before operation, after 1 year, after 2 years, stable.
But
This is real.
there are some factors influence the renal function, such as if the patient is older than 55 cases, or the GFR of the affected kidney is less than 15 milliliter per minute. If you perform multiple thread, the renal function will decrease.
I think Daniel raised a good point that your renal function will be stable because the other kidney is normal.
That's why I'm saying nuclear study.
You need to do a nuclear study.
Yeah.
No, not only the GFR, because the other kidney, one do compensation of the GFR will stay.
We should check the GFR of the affected kidney. We don't use the total renal.
Okay, last presentation, I think is last is the best. Okay, Professor Wu talk about